let me come back first, though. We had some correspondence from individuals in the class through the WebCT and otherwise asking about Exam 1. There was a wide range of performance levels, and I'm not quite certain how to account for all of that, but everyone is aware that we are, at least us together, I'm not an expert at WebCT yet, and I'm in a stage of discovery as part of, I guess, creativity, I'll call it that for lack of a better word. So I appreciate everyone's help with testing the in-class online examination process. We learned a few things that we'll discuss a bit next week. In addition, what I want to do is give everyone one more chance to take the exam online. So this time, however, you will not be required to be in class to do it. Anywhere that you can get on a computer, you will be able to do it. You'll have only one time to take it. It'll be the second time, but it'll be just one additional time. I'll activate it after class today, and it will be available for you to take that one time. And remember, as soon as you start it, you've got your one shot. If you're doing it off campus and your phone line messes up or your connection does, it may log you off, and that's your chance. Then you've got to send get back onto WebCT, send an email through WebCT, and let us know that you had that problem. So we'll make it available right after class, and it'll no longer be available after like midnight on Monday. So we'll have a chance to talk about it a bit on Monday as people have taken their second opportunity. It is second, but it's only one more time, and it'll be set up exactly the same way, except I've got the figure in there, and I'll fix the key. So far, there's been question number 4, where apparently I had a brain fart in class, and I gave an answer that was not the one that I really meant it to be. And so the reminder is that the process of spermatogenesis starts with the mitosis of the spermatogonia and ends with the fully mature sperm spermatozoan in the vas deferens, available, of course, for ejaculation, and it is fully motile and mature and ready to undergo capacitation, and so on and so forth, that we understand for fertilization. But when you look at that, when you see that question again, you'll recognize the answer. And again, your challenge is to find the best answer out of those that are listed. So that's a good example of other ones being right in a certain sense, but some people selected one where oogenesis could have been included. So it's not the best possible answer. So look at them again very carefully in that sense. And then on question 33, I guess it was, I definitely got it wrong, and so I haven't corrected the key yet, but I'll correct it before I post the exam. As I'm aware, I maybe printed something out earlier and didn't get a chance to look at it today as I was studying it. There are no other questions that have come to my attention. If you find any, bring them up. I didn't get all those put in until about midnight on Sunday night, so I was kind of dozing there toward the end. That's why I didn't get that one figure linked to that set of questions. So my apologies for that. This is the first ever at UTSA that we have teaching assistants available as Marco, and another individual, Nayeli Ayala, is helping us. So we're getting geared up to get everything on WebCT way beforehand. Up until now, I've been doing it all on my own. The class I've been doing it. I'm lucky to get things on there like this time, the night before, and just kind of live with the mistakes. and not get the chance to log on as a student and take the exam. So it's quite labor intensive for me, and I appreciate that everyone has paid fees to help make it possible to get the assistance, and things are definitely looking much better. So let's go to something that even looks better than me. This slide with words on it. Okay. So we had reached this point in our discussion before, and we'll continue just with a quick review. We're thinking of the formation of the placenta. We had talked about fetal and maternal parts, different components. We want to look at this area, the intervillous space where the spiral arteries open into it, as do the spiral veins, and we get that circulation. So we looked at this view, basically processes of development, through from the secondary, what are they called? Wow, my brain's dead already. To the tertiary, oh God, brain dead. Villi, thank you very much. You're about to tell me. Thank you. So we discussed the characteristics of primary, secondary, early tertiary, and late tertiary, and are progressing to this level and greater detail to understand this circulation. There are two reasons for looking at this. We could probably even say three. The first, obviously, is that it is key to the survival of the developing embryo and fetus. The second is that it is a very important aspect clinically to understand the relationship, really, of what is a hemochorionic type of placental uterine interaction, because clinically there is the risk of hemorrhage. There's that possibility of the placenta previa if implantation occurs in the wrong location. We saw how some of the amnion and the capsule, decidua capsularis, what else? There was another membrane in there. The chorion, the smooth chorion. Those three layers ended up covering the internal os of the cervix. If this portion of the placenta was covering the cervix, then there would be a significant problem, and that is called placenta previa. The risk of tear at that area and hemorrhage before delivery is completed is significant. The final one is it's just a marvel of nature. This is really a fabulous organ that is produced. There are some other organs, like the lungs and the kidney, that reach this level of sophistication, but the placenta is truly marvelous. So we see the spiral arteries opening into this intervillous space. We see the septi of the cotyledon separating out this entire space, and of course, three-dimensionally, it's completely surrounding this ornate tertiary villus. The venous side is open right into it. You see that the septi that separate these intervillous spaces come very close to the chorion near the umbilical cord, and nearly completely close this space off. The reason for this is that it has to be contained because we're generating an open circulatory system. So this is interstitial space. It is not intravascular space. This is not a blood vessel. It's expanded interstitial space. So it does satisfy the definition for an open circulatory system. So we have to maintain a contained system and a stable pressure. We know it's changing, but it can be stable. So as soon as blood pushes into here, it is drawn away by the spiral vein. follow the vasculature, the pulmonary. Oh, they've got the pulmonary arteries red in this one, and the pulmonary vein blue. So they, Gray's Anatomy, they've got this illustrated with the wrong coloration. It should be the complete opposite. Well, the term cotyledon, then, these are the compartments of the placenta that are partially separated by the decidual septi. Those were those septi I was discussing before. Each cotyledon consists of one or more stem villi surrounded by the maternal blood. The parts of the full-term placenta, then, will include the fetal portion, which is the chorionic plate, and the chorionic villi. The maternal portion will be the decidua basalis that does not separate away. So when we say the placenta has separated, the decidua basalis is staying with the cotyledon, the chorionic villi. It is possible through the stages of pregnancy for premature separation of the placenta, and this can be a significant concern for a variety of reasons. There's the continued risk of hemorrhage, of the loss of the pregnancy, a miscarriage, and as well at delivery there can be additional risks. Sometimes it can become calcified if it's quite early on in the pregnancy. So the placental membrane, let's think about as we use the lungs and the kidney as analogous organs and tissue organizations, let's take a look at exactly what's going on for the exchange of gases and nutrients and waste. Remember that the placenta is functioning as the lungs and the kidneys for these purposes. So the syncytiotrophoblast, the cytotrophoblast, connective tissue of the villi, and then the fetal capillary endothelium are the layers that are taken into account when we're looking at the separation or the barrier for transfer between fetal circulation and the maternal circulation. So the placental membrane is shown here in an illustration, and the lower panel an actual histological sample. And what we see then is facing the maternal side, the thin layer of the syncytotrophoblast or syncytiotrophoblast, and then this would be the intervillous space. And on the fetal side is simply the endothelial cell lining the capillary. And then, of course, whenever you have cells, you have extracellular matrix. So the connective tissue separating these is all that is in between. So it's really exactly the same as the lung and the kidney. So it's only 2 cell layers thick, thereby 4 cellular membranes. We've got the abluminal membrane of the endothelial cell, the one away from the lumen, the adluminal, and so on and so forth, until we go through 4 layers of membrane. So if there are molecules that must be moved from fetal circulation to maternal circulation, but they cannot diffuse freely, they must be transported across 4 membranes. That's the importance of that. There's 4 membranes that have to be involved in the transport. So dysfunction can occur anywhere along the line when we are talking at that level of basic conceptual biology for these types of organ tissue organizational structures to accomplish the transport of molecules from one fluid compartment to another, or one gaseous fluid compartment to a gaseous compartment for the lungs. Well, the layers between the fetal and the maternal blood in the early and matured placenta will differ. So the early portion, the syncytotrophoblast or syncytiotrophoblast, the cytotrophoblastic layer would have been intervening. Trophoblast basement membrane, connective tissue, capillary basement membrane, and the membrane endothelium. So it's much thicker. But the embryo is smaller. It's the earlier embryo, not necessarily the earliest, but the earlier embryo, and it's not quite so large, so it still can allow for or tolerate the more delayed diffusion over the greater distance, diffusion and transport across multi-layers of cells. In the later and more mature placenta, the syncytotrophoblast, the trophoblast membrane, basement membrane, the capillary basement membrane, the endothelium are the only things that are present. There might be some connective tissue between the two basement membranes, but basically it's just the basement membranes. Actually more detailed than that, but we'll leave that alone. One of my pet peeves is being very specific, and the basement membrane actually has two layers, the basal lamina and the reticular lamina. The basal lamina is contributed by the endothelial cell layer, and the reticular lamina is contributed by the connective tissue layer. So this membrane, this basement should be converted to, basement membrane should be converted to basal lamina, and then this connective tissue that they're talking about would have been the reticular lamina part. There really is not a basement membrane. I said I was going to leave it alone, but I can't, can I? There is no basement membrane. There's a basal lamina only. And that's important because in renal pathology, the connective tissue increases in between those two basal lamina and actually introduces a reticular lamina, creating a true basement membrane, and you have pathology that alters the normal functional transport mechanisms, and it leads to kidney failure. So this is the importance of it. A basement membrane is pathology. A basal lamina is normal structural anatomy, so that the function is appropriate. So there is also a tremendous commitment of energy to the placental membrane, because it is very much involved. Not everything is just like the gases diffusing down the concentration gradient. Much of it is requiring energy. So we see two of the functions implicated there: metabolism, synthesizing glycogen to store carbohydrates, cholesterol, and fatty acid, but also metabolism to sustain the active or assisted transport. The gas and nutrient exchange, of course, is beyond just the oxygen and carbon dioxide, glucose, vitamins, electrolytes, antibodies, drugs, and viruses. Of course, viruses and drugs are pathological, or if it's drugs for treatment, although I don't think there are many at all, for, specifically for treating the embryo or fetus. And then endocrine functions. So early on, we know the HCG is a key player, and then ultimately, as we said, the HCG will not be necessary, nor will the corpus luteum, because the placenta itself takes over and begins to synthesize progesterone and estrogen itself. Now recall we said that the HCG represented the very early event where the pregnancy became independent of the maternal hypothalamo-pituitary endocrine axis. Later in pregnancy, the pregnancy becomes independent of the maternal ovary, the maternal ovarian supply of the steroids essential to sustain gestation, progesterone, and the needed estrogen as well. The estrogen is not so much for the sustenance or the persistence of the uterine pregnancy. It is targeting the mammary glands to increase the amount of glandular tissue in preparation for the nutritive aspect of that interface between the mother and the child, of course. So in a more metaphorical fashion, with just a tad bit of humor, if you can accept it that way, your children take control of your life as the mother very, very early on. And they don't let go for a long time, if ever. So these are likened then to the lungs and the kidneys, where basically the same types of things are occurring, and we see everything that is coming in and going out in this part, and I'm not going to take time on that so that we can push on. So the functions of the placenta: the transport and exchange, transport of antibodies, endocrine, mechanical protection, and then barrier for some germs and drugs. So our list before included viruses and drugs, but not all of them can freely pass through. Some are kept out. So the hormones that are produced by the placenta: progesterone, estrogenic hormones, HCG, human chorionic somatotropin, growth hormone, thyrotropin, relaxin, adrenocorticotropin as well. So it's a tremendous endocrine structure. And we have some illustrations here that I'll just flip through and spend very little time on that show us the transformation of this early stage where the primitive gut is just beginning to form, the body stalk, and of course the placental villi. And we see the body stalk lengthening to become the umbilical cord with the yolk sac and the allantois contained within it. The heart has now taken its position in the chest. Prochordal plate is now located here with the oropharyngeal membrane in that position now. So we easily see that the mouth, the oral cavity opening is going to be created here. We see the placental villi beginning to branch a little bit. So they're still very early primary villi on their way to becoming secondary villi. The rest of the chorion has flattened out, the smooth chorion, and the amniotic sac is filling the entire space contained within. All the way, boom, to the gravid uterus at 3 to 4 months. We now see in a very interesting illustration the increased length of the umbilical cord, and the yolk sac still out here in the chorion, the smooth chorion around out here with the capsular decidua capsularis, the endometrium, forming a capsule around this, the decidua basalis and the decidua parietalis, and the mucus plug within the cervix uteri. So the non-placental villi are embedded in the decidua capsularis, and we know that this layer will end up covering the internal os of the cervix. The chorionic plate is this portion here that we described before. So we are continuing to build that terminology. And then we progress to this stage. We see the more mature fetus we should say the more mature embryo, which is now the fetus because it is 8 weeks, completely contained within the amnion that seals itself around the umbilicus, the umbilical cord. Umbilicus is what we have after it's gone, the umbilical cord. And this is the chorionic plate here with the decidua basalis and the chorionic villi shown over here. Well, the yolk sac is out here, and the Biddle duct is running also within the umbilical cord. So that completes Lecture 12. Let's proceed then to Lecture 13. We're striving to stay on schedule as much as possible and doing a rather good job with it. So the labor, childbirth, and complications are what we can begin to discuss now. So we've taken it from conception to the point of having the amniotic sac filled with water. Now we're proceeding to, and of course, transition from embryo to fetus, and now we're proceeding to the next event, and that is the birth. So the labor, childbirth, and potential complications are what we'll begin to discuss now. If we don't complete today, we'll complete on Monday. There are a variety of stages of labor, and we start with a discussion of the first scene here. And this is the dilation of the cervix. So these are the first terms that people will begin to hear. Typically before this, the expecting mother will be informed of the Braxton-Hicks contractions, which are not the labor or pre-labor contractions. They're just kind of exercises that the uterus undergoes. I'll never forget when my wife was experiencing them with our first and second child, and would say, "Oh, I feel it. It's happening. It's happening." You could just feel the tensing of the uterus, and it would become almost rock hard. But it wasn't a painful type of a thing. It was definitely a perceived experience for my wife, not for me, of course, other than placing my hand on her belly. So there are differences, but this is a practice, an exercising of the uterus to get prepared for this first stage when dilation will have occurred. Now, very likely the Braxton-Hicks contractions will contribute to putting pressure on the cervix, and I'm sure contributing to the initial dilation. But it really is a progressive type of a situation, and it's mediated by hormones. Now, some individuals begin to dilate very early on. So you'll hear different terminology, 2 centimeters or a single centimeter or centimeter. I spent a summer in labs in Montreal, Canada, and centimeter stuck in my head there with their more French pronunciation of it. Or the terminology of fingers, one finger dilated, 2 finger dilated, and this is because the intravaginal digital exam is a typical approach used to determine the state of dilation. The nurses that do this become rather, I wouldn't say, they're not apathetic, but quite complacent with it. They just come in, slap on the glove. Next thing you know, they've finished the exam, come out, taking the glove off, 2 fingers dilated, see you next time. Call me if anything comes up. So it's quite a routine type of an exam, and therefore, and it has been that way traditionally, and I very likely will continue. And therefore, this terminology of single digit or 2 digit or 1 finger or 2 finger dilation sticks the clinical setting. So hormones are very much involved. Corticotropin-releasing hormone from the fetal hypothalamus. The placenta is actually a very tremendous source of corticotropin-releasing hormone as well. ACTH from the fetal pituitary. And the cortisol, secreted from the fetal adrenal cortex. So this is, as you all might recognize from your Bio 1 and physiology, this is the stress axis. So later stage of pregnancy, in a sense, is a bit stressful for the fetus. It's stressful for everyone. The maternal estrogen production, the ovarian follicle cells will contribute to the uterine contraction, and this would be the pre-labor contractions, not necessarily the Braxton-Hicks that we had mentioned. So this is a parasagittal view. Actually, it looks more like it is mid-sagittal because we see the urethra in its full extent, and that is in the anatomical midline, the median plane. So this is a mid-plane view. It's obviously an illustration because the Fetus at this stage doesn't just shift all the way to the left or the right. They take up everything, right, left, up, down, all over the place. But we see the placenta is placed in the superior posterior portion of the uterine wall. And the amnion, the smooth chorion, and the decidua basalis, even though they may have broken down some at this time, we still get our pop-ups here, is the only barrier between the fetus and the cervical canal. Cervical mucus plug will be released at some stage in early labor as well. It wasn't on the list, but we know that it must occur at some point. So we all recognize this as the stage that people talk about where the baby has turned. And of course, we use fetus because that's the fetus until when it's in here, it's the fetus. As soon as it's out here, it's a baby. It's a neonatal infant. But the baby has turned, so their head is down. And then they drop. So these are terms that we hear just around the house as mothers and sisters and all the girls that are in pregnancy will be happy to share as they're undergoing these transitions with excitement and discomfort. This is that stage of turned and dropped into the true pelvis, and now there is additional stretch and pressure on the cervix, of course. So the degree of cervical dilation, it's measured in inches, finger breadths, millimeters, centimeters, feet, and as I said, typically it is finger breadths. It's the most common, even though centimeters is sometimes used. The most common, so the best possible answer for this question, therefore, would be in finger breadths. So 1 finger, 2 finger, and so forth, because it is the most practical. The cervical dilation, of course, is complete in this case. There is effacement here because and crowning because from the external view, the head could be seen. So the labor has reached the point where there is the fetus is now within the birth canal. So this continuation then of the hormones that mediate it, maternal oxytocin from the maternal posterior pituitary is very important. It is actually crucial. So it stimulates the uterine contractions. We can now think of it like this. Very early on, the baby, if you will, becomes independent of maternal pituitary by secretion of human chorionic gonadotropin. Later, through the placenta, becomes independent of the maternal ovaries by secreting progesterone and estrogen. When it comes time to come out, mommy's pituitary says, guess what? Oxytocin's coming and you're coming out. So the maternal pituitary, in the end, takes over control again. And from there on out, it's left to the mother's brain to try to take over control as the baby cries and screams and all that stuff happens, and there's a total mixture of emotions. So prostaglandins are another source of hormones that are actually produced within the endometrium and trigger the contractions very potently as well. Oxytocin is an important one to keep in mind, first because it is originating from the maternal pituitary, but second is because a synthetic form of oxytocin called pertocin is what is used to induce labor in individuals where it is medically indicated. And it's never the same twice, and it's never the same for different individuals, 2 to 22 hours. So it gets a little easier as you go on and have more and more. So there's a term that we can introduce here. A female that has never had children is called the clinical term, technical term is nulliparous, N-U-L-L. So the IPOROUS is referring to having been pregnant. The multiparous is the term for individuals that have had more than one infant, actually been pregnant more than once. It doesn't necessarily mean there was a delivery. This means that it was pregnancy. Or uniparous if there's only been one pregnancy. So from nulliparous to multiparous, it can go from 22 hours to 2 hours to change. So here is an illustration of this endocrinology and the stimuli that are involved. So the fetus drops lower in the uterus, as we saw. There is cervical stretch. The stretch receptors in the uterus carry information to the brainstem through the vagus nerve. And from the brainstem, there's information that it ascends to the hypothalamus, where there are neurons whose axons terminate in the posterior pituitary. And, of course, oxytocin is the neurohormone contained within those neurons and their axon terminals that end on the capillaries within the posterior pituitary. These neurons are going to start firing and dumping out oxytocin into the blood, and this will stimulate the prostaglandin secretion. Actually, it's synthesis, because these are lipid-soluble. They are released as soon as they're synthesized. It stimulates the synthesis and secretion of prostaglandins, both of which, the oxytocin and the prostaglandins, have receptors on the uterine smooth muscle, the myometrial cells, and when they bind to their receptor, they change the membrane characteristics, cause the depolarization, the calcium, intracellular calcium releases, and so on and so forth, to lead to smooth muscular contractions. And, of course, this is a positive feedback system where there's more contraction, more pressure, more stretch, more oxytocin release, more prostaglandin, more stimulus to the uterus. So when they're telling the mother in labor, don't push, it takes a tremendous amount of brain power and concentration to interrupt or subdue this positive feedback mechanism. So during labor, secretion of blank stimulates contractions of the uterus. So obviously it's the oxytocin and the prostaglandins that do this. I've been the pre-health advisor at UTSA for quite a few years now. So there's been chances for students that have worked with me to have completed medical school and gone through all their training and everything. And I've been informed by a recent graduate of med school, actually now he's completed residency and is in specialty training, that episiotomies are not performed anymore. They're now allowing for natural tearing again. But I remember when my wife delivered our first child that I was down watching everything as it was happening. And then when it came time for the episiotomy, the obstetrician just grabbed some scissors, grabbed the posterior vaginal wall and the skin in the external area, and just went with the scissors and cut like that. And man, I was out of there quick and back up to the other end going, push, push. This is quite an interesting surgical procedure. And now apparently I'm not sure if they have the massaging of this area included in the procedure, but the common practice has returned to allowing for natural tearing to occur. Either way, there are times when you're happy to be a male, and those are my favorite times to be reminded that I'm a male and I never have to go through that. Anyway, the incision is made to widen the vaginal orifice, aiding in fetal expulsion, which is true. So if The reasoning, of course, is that if there is extreme stretch, different from individual to individual, so typically performing an episiotomy was still at the discretion of the obstetrician. Some have it as a common practice every time. I do it because you have a window of time to do it, and I don't want to be stuck with making the decision because we don't want to tear. And the feeling was that it was a cut of known shape and size, and it could be stitched up more carefully and cleanly and minimize scarring and all types of things like that. And now it's changed. But anyway, the answer to this is obviously true. Relaxin is hormone produced by the placenta and ovaries, and the function of this hormone is to relax the pubic symphysis, as the name implies. So the pubic bones, as we know, meet anteriorly and form a symphysis, the pubic symphysis, and this structure has to be relaxed to widen to increase the diameter of the pelvic outlet, which is obviously very important for delivery. And thereby, of course, the name relaxin related to that function. So the act of giving birth is called what? Anybody know what it is? Parturition, right? Postpartum depression. So partum is parturition. So the act of giving birth is called parturition. So let's take the last couple of minutes just to talk about stages 2 and 3 very quickly. The second stage is expulsion. The fetus descends to the birth canal, lasts 30 to 90 minutes, and the fetus becomes the newborn or neonate immediately upon complete externalization. The third stage is placental. So the placental expulsion will occur along with the fetal membrane. So very early on, the cervical mucus plug will be expelled in early stage 1 labor. The water will break, and then things will proceed from there. And then in the end, the amnion has remained within the intrauterine cavity, and it must be expelled along with the placenta, which, of course, we said includes the decidua basalis. And this lasts for 10 to 30 minutes. Quite often, an injection of Pitocin will be given again at the end, or in some cases, they'll have the infant suckle almost immediately because the mechanical stimulus to the nipples triggers the release of maternal oxytocin. This is key to cause the contraction of the uterus after the decidua basalis has been removed to minimize risk of hemorrhage. So here we see the full presentation of the head, the shoulders first. The placenta has not released itself yet, and this, of course, is important because until full externalization and shifting in the fetal to neonatal circulation with contraction of the umbilical vessels and shunting of all the fetal blood into the neonate, the attachment of the placenta is essential for nutrient and waste and oxygen supply. A lot of metabolic activity in the neonate, or let's say the fetus, surviving this stressful event. And then finally, of course, the decidua basalis is shed along with all the rest of the afterbirth, as it would be called. Afterbirth includes placenta and the amnion and the umbilical cord. And then the uterus must contract to constrict all of those spiral arteries and veins that were open into the intravenous space. So as we finish up class, just this final stage then, continued uterine contractions, constrict those arteries, and it lasts between 1 to 2 hours. and we will start on Monday with the consideration of these questions and finalize this discussion of Lecture 13 and move on to Lecture 14.